Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Roger Goldberg of Walnut Creek, California. And welcome to Retina Synthesis, or welcome back to Retina Synthesis, Roger.
Well, it's great to be back.
So at ARVO, you presented some important results on the 18-month results in the pivotal Derby and Oaks clinical trial of pegcetacoplan for treating geographic atrophy. So can you tell us a little bit about the molecule involved and why it's supposed to work?
Sure. So pegcetacoplan, or APL2, it of course doesn't have a easy to say branded name at this point, but it's a complement factor 3 inhibitor. And if you remember kind of the complement cascade, it can get activated in a variety of different ways. The classical pathway, which is like antigen antibody complexes, the alternative pathway where you get these kind of cell surface markers that on pathogens. And there's also this mannose binding lectin pathway, which is kind of based on the sugars on the surfaces of various microorganisms. And all of those things converge onto C3, which then triggers kind of the remaining downstream cascade of inflammation and opsonization, and eventually the formation of something called membrane attack complex, which is kind of the very downstream final product of the complement cascade, which causes cell death and secretion. And when they do genetic studies of patients with macular degeneration, whether it's the early form, the intermediate form, or the more advanced forms of macular degeneration, there are always numerous hits in the complement cascade, numerous kind of pathogenic mutations that seem to be associated with macular degeneration, regardless of the stage of macular degeneration. And in particular, then when you look, let's say, like histopathologically at drusen, you see a lot of complement deposition. So there's been this strong feeling now for, coming up nearly on 20 years of the kind of central role that complement plays in the pathogenesis of macular degeneration. And so Apellis, which makes the pegcetacoplan, the C3 inhibitor, they did a phase 2 study called the Philly study, which showed that you could slow the growth of geographic atrophy by giving these injections either monthly or every other month. And it was the results of the Philly study that led to their phase 3 programs, which they called Derby and Oaks. And Derby and Oaks were, twin studies. They were very large, over 1,200 patients total. And patients were randomized either to monthly pegcetacoplan, every other month pegcetacoplan, or sham injections. And then they're going to be followed, actually, the primary endpoint's at 1 year, but they're followed out to 2 years. And then there's actually an extension study as well. So the patients will be followed even further.
So what were the results?
So they had previously shared the 12-month results. Those are, of course, the primary endpoint. This was the first time, though, that they have shared the 18-month results, was at ARVO. And at 12 months, we saw a significant reduction in the growth of geographic atrophy in the Oaks study, which was 16% reduction in the growth in the every other month arm and 21% reduction in the monthly arm. In the Derby study, it showed a smaller reduction, 11 and 12% reduction at 12 months. And those p-values just missed statistical significance in the Derby study at 12 months. 0.06 was the p-value in the monthly arm, for example. So now they shared the 18-month data. And at 18 months, what we see is continued separation of the curves. So the percent reduction actually ticked up a little bit, 16 and 22% in Oaks and 12 and 13% in Derby. And for these, the p-values were less than 0.05. They were what they called nominally statistically significant because it wasn't the primary endpoint, although it was a pre-specified endpoint. They're what are called nominal p-values, and it has to do a little bit with kind of the statistical plan and the various statistical hierarchy that the biostatisticians create when they're designing these very large and complex phase 3 trials. So overall, we see, though, kind of just increased separation of the curves. That's, of course, a good thing because it means more preserved retinal tissue over time. And I think probably the most interesting slide that was shared, the most interesting data, was they broke down the impact of pegcetacoplan over time. So what was its impact in the first 6 months? What was its impact on slowing the rate of GA in the second 6 months, from month 6 to month 12, and now from months 12 to 18. And here we saw a very clear increase in the magnitude of the effect over time, particularly in the Derby study. The Derby study, of course, is the study that just missed its primary endpoint at month 12. And when you look kind of just in the first 6 months of Derby, there's a very small reduction in GA growth, about 6 to 8% in the monthly and every other month arms. But then from month 6 to month 12, it jumped up to 16 and 17%, and it stayed around that level for months 12 to 18. And it kind of gets back into the more normal range of what we saw from the Oak study, the other study, as well as in the phase 2 Philly data. So it kind of suggests when we're sitting there scratching our heads to say, well, why did Derby underperform relative to Oaks and Philly? It looks like it's from the negligible effect that the drug had in the first 6 months of treatment, because after those first 6 months, it actually does seem to start to make a difference in slowing the rate of GA growth. And then, the data was broken down by foveal and extrafoveal lesions. Of course, extrafoveal lesions tend to grow faster, and the drug seems to have a stronger effect. We see the magnitude of the reduction in GA lesion growth in the extrafoveal population quite a bit larger. In Oaks, it was 17 in the every other month and 33% in the monthly. And in Derby, it was 17 to 23% for the monthly and every other month arms. So we see a little bit greater magnitude of effect in extrafoveal patients. And these, of course, are the patients whose vision we really want to save. So it's good. I think it's good to see that the patients where at least I'm most excited to intervene before the central fovea has been taken out, that the drug works kind of even better in that population of patients.
Was there a difference in response between large and small lesions?
So that's a great question. We know that larger lesions in general grow faster than smaller lesions. And it probably has to do not with the total area of the lesion, but with the kind of the surface area, how much perimeter space there is, because the more perimeter space there is, the more room there is to expand. And so the study tried to balance the size differences between the sham treated arm and the pegcetacoplan treated arms. But the way they did it is they just did they basically equalized it by more or less than 7.5 square millimeters of geographic atrophy. But of course, it's not, in the real world, GA isn't just binary, it's a sliding scale. There's GA at every possible size of square millimeters of geographic atrophy. And so they do see a difference, and they actually, Sunir Garg presented how some of these baseline differences, including lesion size, may have impacted or affected the results in Derby and Oaks. But yes, larger lesions grow faster, and it's kind of easier to show an effect the faster the lesions grow.
So do you think there's a future for anti-complement therapy in geographic atrophy?
I do. Of course, this right now is a relentless and slowly progressive disease, and there's no treatment available. So although, look, would I love a drug that stops the disease altogether or even reverses, vision loss associated with GA? Of course, those would be what I'd call a home run or a grand slam. This is more of a single or a double, but it's a single or a double in a disease where we've never had a base runner. So I think from that standpoint, I think I and the retina community, and frankly, our patients are eager to have something out there to try to slow down this disease. So between APL2 here, pegcetacoplan, Iveric, of course, has a C5 inhibitor in development, the GATHER studies. So I do think there's a future for complement inhibition in geographic atrophy.
Well, thanks so much, Roger, for your insights into this ongoing story about APL2. And we'll see what the FDA has to say.
All right, very good. Well, thanks for having me on.
Thank you.